Yes, sir. You can start now. Thank you. Madam, PPT is not full screen. Kindly do it full screen, please.
Good evening. Myself, Dr. Amrita, pediatric resident, Sion Hospital. Today, presenting a long case for Thursday clinic. I'm presenting case of 10-year-old female, second by birth order, born third degree consanguineous marriage, brought by mother with complaint of fever since 2 days and two episodes of paroxysmal events. The child has a significant developmental history, hence starting with the birth history. Birth history, child was a full-term vaginal delivery, cried after stimulation after 2 minutes with birth weight of 2.5 kg. There was no NICU stay. Breastfeeding initiated within 2 hours of birth and discharged on day of life 3. But child had attained delayed milestones compared to the elder sibling as per mother. Child had attained head control at 8 months and sitting with support at 11 months, standing with support at 13 months, and walking with support at 15 months, walking without support by 1 year, 6 months of age, and walking upstairs and downstairs with 2 feet per step by 2 years of age, running at 3 years of age. And then fine motor, hand opening 3 months, reaching for objects at 10 months, mature pincer grasp at 1.5 year,
Ma'am,
scribbling
sorry
by
to
1 year,
disturb
8
you.
months,
Ma'am, sorry
eating
to
with
disturb
hand
you.
2 years,
Wings
social,
are not moving.
child is not
They are
able
not
to.
moving.
Pallavi madam, you can hear,
Yes, yes, sir. But slides are not moving.
and the slides are also seen, right?
Yes, slides are seen, but those are not moving.
They are not moving.
Yeah. Only first slide we can see. And PPT is not full screen.
Are they moving now?
Not yet, sir. Kindly share again, sir. Close the window and share again. Stop sharing once and share again.
एक बार शेयर करके वापस शेयर.
सर हाँ शेयर स्टॉप शेयरिंग करिए अब वापस एक बार शेयर शेयर करिए. Select the full screen window.
Are they moving?
We are yet to see the slide, but it's coming. We can see first slide now. Kindly move the slide, next slide, so that I can
Here,
click
but
on the
it's
present.
not moving, right?
No, it's not moving. Click on the presentation, on the present, and then use the keys. It will move. Sir, Sion Hospital ID is not visible now.
Are they moving now?
Sir, slides are not visible. It is not shared.
No, she has shared. We have some internet issues, I think.
Because
So
I'm
I
not
think
able.
we'll
Huh. We are not able to see the.
maybe we'll have to go with the audio only today.
Okay, sir. Okay, no problem. No,
Yeah.
it's yeah, it's
Okay.
sharing.
Okay.
Yes. Kindly try moving the slides, or else we'll go ahead like this only.
Fine motor milestones. Child had hand opening at 3 months, reaching for objects at 10 months, mature pincer grasp by 1.5 year, scribbling at 1 year, 8 months, and eating with hand by 2 years. Social milestone, child does not recognize mother and there is no social smile. Language, attained cooing at 4 months, bisyllable at 1.5 year, and did not attain further milestones. And there is history of difficulty in hearing. And child was doing well as per mother till 7 years of age. Then there is history of admission at 7 years of age for bronchopneumonia for 8 to 10 days of stay and required mechanical ventilation for 2 days. There is no history of any convulsion during the hospital stay, and some investigations were done and was told to have some heart disease. According to the mother, post the admission, child has been not able to walk and unable to eat or drink by herself. And there is history of changing diapers and history of difficulty feeding in the form of taking longer time to swallow the food. Currently, child has come with fever since 2 days, which are high grade. Documented temperature maximum is 104 Fahrenheit, not associated with rigors, and relieved on medication. Child was active during interfebrile period. And one episode of paroxysmal event, same day of fever, around when a form of tightening of four, followed by tonic-clonic movements of all four limbs, lasting for 10 minutes at the height of fever spike. And child was taken to local hospital where she received some medications and the movements were aborted. Next day, child had similar paroxysmal event with the same semiology and brought to Sion Hospital and aborted by medication. No history of irritability, excessive cry, lethargy, or vomiting. No history of trauma. No history of loss of consciousness. No history of any history suggestive of cranial nerve deficit. No history of new onset focal neurological deficit. There are no history of any abnormal movements. No history of progressive increase or decrease in the head size. No history of cough, cold, breathlessness, or crying during maturation. Anti- Antenatal history. Age of conception is 29 years. It was uneventful. First trimester, there is no history of fever with rash or excessive vomiting or exposure to radiation. No history of burning, maturation. No history of bleeding. Regular ANC visits were done. Second trimester, quickening felt at 5th months of gestation. Anomaly scan was done and told to be normal. Third trimester, fetal movements were well perceived and no history of bleeding, no history of leaking or per vagina, and no history of pain abdomen. Child is immunized till date. Diet, there is history of difficulty feeding. Child takes longer time to swallow the feed and takes semi-solid and liquids. There is calorie intake of 650 kilocalories and protein 15 grams. Deficit being 550 kilocalories and deficit of protein 3.7 grams. Socioeconomic and family history. It is a third degree marriage. Has an elder sibling who is 21-year-old, healthy, and there is no history of any abortion in the mother. No history of similar complaints in family, and they belong to lower middle class. as per modified Kupuswamy classification. Uh,
So today it's a 10-year-old child, right? So 10-year-old child has come with two seizures. So today when this child has come with two episodes of seizures, how will we think, what will be our thought process, and then we'll go backwards. So in general, we have discussed this many times. Whenever a older child comes to you for a seizure, what is your thought process? Come ahead, all of you. Come, you can come here. So when an older child comes with a seizure episode, what is your thought process? Ask for the mic.
To rule out hypoglycemia and hypocalcemia first.
As a concept, first tell me, why should an older child have hypoglycemia and hypocalcemia? So that is a little later branching. What is the first concept that you should develop? Is this seizure acute symptomatic, remote symptomatic, or idiopathic? That is your first branching concept. So has something happened today? Is it a meningitis? Is it a intracranial infection? Whatever. So is this seizure symptomatic of something that has happened today, yesterday? That is the one question. And if not, then whether it is something to do with the past. That's how you will be alerted that something is there in the past. Right? So now take it further. What can acute symptomatic be?
Infectious causes like meningitis.
Yeah. So you look for history suggestive of intracranial infection, meningitis, encephalitis. What else?
Space occupying lesions.
Okay, space occupying lesions. So history suggestive of that. Then what else can be acute symptomatic? Trauma. Very good. And then comes your metabolic causes. Of course, then you have to correlate it with the age, whether at that age you expect those metabolic causes to come up, like hypoglycemia, hypocalcemia, etc. Right?
So I think largely we said acute symptomatic. Why? Because the child was absolutely all right prior to that. Let's believe that. This child has had some problem. So let's believe it was acute symptomatic in a normal child. Then you said trauma, but trauma is the starting point and a seizure is the end result. Nobody forgets trauma that can cause a seizure. It has to be a severe trauma. Therefore, it's not trauma at all. Same thing is about infection. This child did not have fever, had fever. So now you have a fever and followed by that a sudden acute episode. Obviously, an intracranial infection, right? Where is the debate? Would you agree this is an intracranial infection? We said meningitis, encephalitis. Yes, fever. So, what's your take on this? Only with this story 10-year-old, healthy, normal, with fever and a seizure.
Other signs of meningitis or intracranial infection like vomiting, irritability, lethargy are not there.
So the point is, he said ask for related symptoms. Okay. And the only related symptom could be vomiting, even much before that. Because when meningitis starts, it takes time to develop raised ICT. So those symptoms and signs come up later. So the first thing is acute meningitis at 10-year-old age cannot just come with seizure alone. First, he has to start with irritability, headache, vomiting. If nobody cares to find out or treat him, Then he starts deepening in his sensorium, and then he may develop a seizure. Seizure is a little later onset in an older child or an adult. This is 10-year-old, too old. At 10 year, no bacterial meningitis should ever cause seizure unless you misfired totally. So that is out at this age. Okay. His seizure has come up within 48 hours of fever. In meningitis, even headache, vomiting may not arrive in 48 hours. And thereafter, irritability, more headache, more vomiting. Thereafter, the rest of the syndrome. So this is not bacterial meningitis at all. Could it be viral encephalitis?
Viral encephalitis will have altered behavior and changes.
It will take time, no? We said in meningitis, it doesn't come up at all early. But virus, it comes early, you know? So the point she's making is that typical viral encephalitis starts with encephalon involvement. And encephalon involvement is one is seizure, another is some change in sensorium. He may not be drowsy, unconscious, coma, whatever, but certainly he's lethargic, he's not looking normal, he doesn't respond much, or he responds only to pain, or otherwise he's sleeping. When you ask him, he opens his eyes only. So there is some encephalon involvement and not an isolated seizure. In fact, the seizure will follow the encephalon involvement. So this is not viral encephalitis also. Okay, could it be a tuberculous meningitis? Silent focus? Okay, you don't know the previous symptoms. There may not be any symptoms of TB, and suddenly it gets worse into neurological manifestation. So, what's your take on it being TB meningitis?
Longer duration.
You're right, but you are not at a postgraduate level. What is longer was 1 day shorter. Okay, we want to pick it up at that stage. We believe there is no PUO. PO is pyrexia of unknown origin, no. Pyrexia of unknown knowledge of the physician. So you're right, but you are at a higher level. So my question to you is, does meningitis cause seizure? Seizure is an encephalon involvement, no? Then can meningitis cause seizure?
It gets complicated, then it may cause.
Complicated. So then TBM should be complicated. And what complication? From meningitis, the infection is crossing over to the brain parenchyma. Is that
Yes.
what you mean by complication? Complication of pneumonia is empyema, extension of infection from lung to the pleura. Could it be pleura to the lung? Extension. This is something like that. Meninges is a cover.
Irritation of meninges and subsequent extension into subdural space.
All that will not affect the encephalon. Okay. And a seizure is an encephalon problem. So if something is wrong in the meninges, subdural, epidural, whatever, why should it cause seizure? Give a thought.
So the inflammation which is happening in the meninges, it is crossing the blood-brain barrier and affecting the cerebrum.
Correct. What sir is asking is that in TBM, when they get a seizure, is the infection in the parenchyma of the brain? That is why it has caused a seizure, or there is some other mechanism to the seizure?
Sir, some other mechanism. So it's
What is
immune
that?
it's immune mediated, like vasculitis.
Vasculitis, he said.
See, immune mediated occurs when there is a reason for immune disturbance or immune reaction, like a tuberculosis. In a bacterial meningitis, is the extension of infection. So in a bacterial meningitis, it is one because of the intracranial pressure starts rising, the blood supply starts getting affected. After all, when the tension increases, the blood flowing through the arteries, the capillaries are not moving well, and the blood returning through venous circuit also may not get out quickly. So that is one cause related to raised ICT. In TB, it is immune mediated. Bacterial infections cause immune mediation after some gap, whereas the TBM, immune mediated symptomatology, is a part of the syndrome, comes together because it is a tuberculin to which the immune system is reacting. So point that we are making is acute bacterial meningitis never causes seizure unless you have allowed it to worsen over time. In a TB meningitis, again, the symptomatology of a chronic meningitis which has been missed, chronic tuberculosis which has been missed, you may get a seizure as the first manifestation in an infant, but not at 10 years. At 10 years, again, it's meningitis. So it should behave like meningitis, headache, vomiting, etc. And the encephalon involvement would come a little later. So this is neither bacterial, tubercle, viral. Could it be malaria? 2 days of fever and a seizure. Falciparum. Come on, give a thought.
Have you all seen falciparum malaria or cerebral malaria? How do they present clinically?
Fever with chills and splenomegaly, vomiting. I think
Yeah, but what is the timetable of CNS symptoms? Means when do you get seizures and what happens along with that?
the it is not on the first or second day of fever, so it takes time.
Okay. So it may take a little longer. And what else? Again, it has to be with alteration of
Sensorium.
sensorium. No? It can't just be a seizure, right? So therefore, it's not cerebral malaria also. So as sir was saying, trauma we have ruled out. Metabolic, we said this is not the age to get hypoglycemia, hypocalcemia. Intracranial infection we have ruled out. So this way we are not, we are saying that it's unlikely to be a acute symptomatic seizure. So that raises the possibility whether is it remote symptomatic. So did something happen in the past, right? Okay. So now your past gets linked.
Now, can it be idiopathic? We have ruled out acute symptomatic. Okay. Could be idiopathic.
After ruling out the possibility of remote symptomatic epilepsy.
Yeah, but
Okay.
I'm not giving you the history. Or I would say past history is absolutely clean. Then would you say it's idiopathic?
Past history depends of current any metabolic disturbances or current history.
Could this fever has triggered some metabolic problem and therefore manifested it? Many metabolic
Possible.
problems are triggered by a trivial infection. And infection disappears, but the trigger manifests with some complication. Immune
But
and metabolic are often triggered.
but there
So
will be history of trigger.
haven't you seen hypocalcemic seizure in a child coming with 2 days of fever and hypocalcemia? Okay. So why have you ruled out metabolic causes? We have seen hypocalcemia at 1 year, 2 years. Okay.
10 years of age, hypocalcemia is unlikely, sir.
So could he not have had rickets and he has no symptoms? And on examination, you will find rickets. And rickets at 10 years is not worsening like a rickets of 1 year or 2 years. Okay. So you're right. But now put an argument against what I said.
The serum calcium will be
No,
maintained.
but we are only on history. We are not even examined. So 10-year-old with rickets is not a deficiency rickets. It's obviously a resistant rickets. Therefore, he has no reason to come out first time with that. But much before that, he has a growth failure. He has many bony abnormalities. And therefore, that is out. So hypocalcemia is out. Could it not be hypoglycemia? Suppose this is a glycogen storage disorder. He has an abdominal distension. He has not complained about it. And now he's throwing up a seizure.
He will throw a seizure in very, very early age, sir, since uh, hypoglycemia can manifest earlier also. At 10 years of age, unnoticed cannot be.
So you're right that a metabolic disorder largely would have presented before that. Okay, but theoretically, you should keep that in mind for the first time. Would diabetes present at 10 years with a seizure? Now, don't say that it must be from early infancy. Diabetes comes at that age, no? Do you think it's a diabetes throwing up a seizure?
Decay in cerebral edema.
Must be other features of diabetes like previous complaint, polyphagia, polyuria, weight loss.
The diabetes can be silent. Okay. And in children, it could be acute. And therefore, you may have to ask polyuria, polydipsia, polyphagia. That doesn't come out in the history. But what comes out is the child suddenly starts feeling tired and then gets into ketoacidosis. What are the symptoms of ketoacidosis?
Abdominal pain, vomiting, right?
Okay. Therefore, this is not diabetes related. Can diabetes present with hypoglycemia? Go to adult ward, they get admitted with hypoglycemia as well.
Insulin they're taking is
So, treatment is not compliant. Therefore, they have not taken insulin. Okay, fine. So, diabetes, hypoglycemia, all is out. Organic acidemia, etc., are all conditions of hypoglycemia which cannot come for the first time at that age. Therefore, this is not acute at all. But to me, it must be idiopathic.
So see, when we say idiopathic, what we mean is if you think it's not acute symptomatic, something is not wrong now, and if there was nothing in the past also, then whether this is the beginning of epilepsy, that is the meaning of the word idiopathic. Okay. So what is your thought process on beginning of epilepsy at 10 years in this child?
After all, after two seizures, he has been okay, no? There's no further seizure, there's no unconsciousness, no nothing. So it's an idiopathic. So the question is, how do you expect an idiopathic epilepsy? We'll call it when it recurs. But could be the forthcoming epilepsy in this child? And the answer is almost always a single self-limiting episode to begin with. Okay. This child had a repeat twice. Okay. Which is unusual. And therefore, the first episode of so-called developing epilepsy is a self-limiting single episode. And therefore, after all, idiopathic is a diagnosis of but by idiopathic we mean recurrent seizure, which is not triggered by anything. This is triggered, fever. Okay. And therefore, we come to a conclusion right in your first slide that this child has to have a remote symptomatic, and you would have asked a question related. But now you ask a question to this parent. He said, no, no, it's not, he's not retarded. He understands everything. He walks, he runs, he goes to school. He's not doing well, but so what? Do you think that's a brain damage which will cause seizure? Then the history would be, एक बार ऊपर से गिर गया. Okay. But nothing happened. So we forgot. Would that be the remote symptomatic. What is remote? Something happened in the brain. Okay. He has had pneumonia once, by bronchopneumonia. Could it be he was hypoxic that time? Okay. And that damage has remained. And we call it idiopathic. What's your comment on that? Because this is fever triggered. Okay. Have you seen pneumonia with a seizure? No. So, by and large, we go by what you have been seeing in 3 years, maybe 2+. Yeah, given allowance. So, that is not possible at all. To that extent, we would say that we possibly know this has to be remote symptomatic, but there is no history at all. What I'm trying to say is that history could be very subtle. For example, he looks like autistic, but he's doing all right. But that's a brain problem. Okay. He's a he's a bit slow in understanding. That's a brain problem. So brain problem may not be obvious, delayed milestones, etc. Okay. But I'm sure you gave some history. Birth was all right.
So, yeah,
So
cried after 2 minutes,
yeah.
but
So is cry an important thing at birth? So everybody
those of
should
you
cry.
who heard this history, what do you make out of this cried after 2 minutes? No, I am saying in the, so sir is also asking that when we say cried immediately or cried later, what do we have in mind? Is the cry important or something else is important? Oxygenation of the brain is important. So you are trying to decide in your mind, was oxygenation proper or was it affected? In this child, we got a history that this child cried 2 minutes after birth. Now tell me, in this child at that time, was the brain oxygenation affected or no by other history that she gave?
Neonatal encephalopathy letters.
So she said no history of neonatal encephalopathy, baby fed within 2 hours, no seizure that time, no other abnormality. So that is important. So then that 2 minute is not relevant in terms of hypoxia. It didn't cause any
And what is neonatal encephalopathy? What do you ask in the history?
Lethargy and not feeding. Seizure.
persistent crying, irritability,
Not taking feeds well.
not taking feeds. Okay.
So for that, you need to go to your undergraduate days, and you might have attended few deliveries of normal babies. How does the baby behave at birth? And if that behavior is not normal, it's called neonatal encephalopathy. What is the behavior of a baby? Baby who has been normal with normal birth process cries vigorously, okay, bonds with the mother, crawls over the abdomen to the breast, starts sucking vigorously, remains awake for next 15-20 minutes, and thereafter goes to sleep for next 3-4 hours, and then wakes up and starts feed and sleep cycle. Anything going wrong in this? The baby cried immediately and stopped and did not bother to even make a bonding sucking abnormal. Baby never stopped crying, abnormal. Baby stopped crying, went up to the breast, but was not vigorous in sucking, abnormal. The baby sucked for just a minute or two and went to sleep, not abnormal. Must remain 20 minutes awake. And thereafter, when he slept and never got up for a long time or got up in next 20 minutes, all that is behavioral abnormality of a neonate. In fact, I must repeat this several times I've done in the last 50 years, that the, one of the neonatologists has given a very good simile to this for us to understand. Tomorrow you will finish your MD, DNB, go abroad, and then you will come back after a year for a vacation for a few weeks. And your family will come to the airport to receive you. Okay. to them? No, you are away only. If you go now back to your house, nobody is going to come to receive you. You take a bus or taxi and come home, right? But that time, isn't it? And entire family goes to receive, and they are so anxious. They are seeing through the glass window panes whether you can see her coming out. Okay, pick up her luggage. What is that? You are so much wanting to meet her, right? And when she comes out, then you hug her. Okay, 5, 10 minutes, 20 minutes. Then you say it's 2 o'clock in the morning. Let's go home and sleep. And after a good rest, we will continue talking. Newborn exactly does that. Mother is wanting to see the baby. The baby wants to see the mother. There is no time to wait. They are looking for it. When they meet, 20 minutes, both are tired. They must go to sleep. But before going to sleep, they must bond. What an excellent simile, isn't it? You will never forget to ask details of neonatal encephalopathy. Some of these authors have made it so simple for us to understand, and that is from next time you will say, no neonatal encephalopathy. And you would have asked all these questions. If you say this in an examination and the person asks, you can talk for 10 minutes on this, and he said, time is up, I cannot fail you, you're just gone past. Because so much of depth, right? So this is where we stand.
So now we are on that neonatal history, and then you gave us the developmental history.
So neonatal was okay, right? He was not given oxygen, ventilation, nothing. So that's not the cause of delayed milestones. Now tell me the cause of delayed milestones.
So there's a history of milestones that you have given all along. Did you hear it? And those of you who heard it, I want your inputs into that. Take one by one: gross motor, then fine motor, then speech and language. So you remember her history of gross motor? What did she say?
Minimal delay. No?
Initially, there was delay, sir, but then she caught up till 3 years. Then again, after when she had pneumonia, she lost.
That bit your history was not clear, but the point I want all of you to pick up is that her gross motor seemed to be delayed only in the beginning, and after that it was a fast catch up almost to normalcy.
Standing, walking, everything. Yeah.
So therefore, that's something to be noted, that gross motor was became normal quickly. What about fine motor? What's your interpretation of fine motor?
Fine motor also, she had picked up by 2 years, sir.
Okay.
But language and social, she was lagging.
Very good. So now what does this tell you? When you have a delayed development where language and social is lagging, but gross and fine motor is not so bad. What does it mean?
Affection in frontal lobe.
Hearing impairment.
So hearing impairment, would social be also bad?
Social smile at least can attain with the hearing loss also, but child did not have social smile.
Social also, as you grow older, you have to take it as cognitive also. So social and cognitive. So language, you may link it to hearing impairment, but when social and cognitive is also affected, and these two are affected, then what it means is that motor part seems largely okay. So this is not cerebral palsy. That is the point. Okay. Whether it's some other syndrome, genetic, whether mental subnormality, all that we will have to dissect further, but it's not cerebral palsy, right? Okay. Now you said till 7 years the child was otherwise okay, and then there was that.
Which means that even cognitive social language had picked up.
Cognitive and social was lagging only, but motor wise, she was all right.
And language?
Language, no. Only she could tell bisyllables. Papa, mama, dada.
So language never picked up at all. Social cognitive also reasonably lagging behind, and motor have picked up
Intact.
right from beginning. Fine.
Then you said after that illness, What happened? You said there was loss of attained motor milestones. Elaborate on that.
So after that, child could not walk, and child could not eat by herself. She had to be fed, and the language and cognition was similar to the prior.
So between 7 and 10, all domains had been very poor. So what does that mean now? Cerebral palsy is out. But what is this funny thing? A bit of a delay, but thereafter motor system improved. But by 7 years, you're still lagging behind social, adaptive language. And thereafter, an illness makes it even worse in motor milestones as well. So at present, all four domains have gone, but their appearance of lagging behind has been different. What does it convey to you? Give a thought, doesn't matter. Funny, no?
So after a illness, if a child, not a CNS illness, a respiratory illness, if a child, so to say, loses motor milestones, what does it mean to you?
Sir, we'll have to rule out pseudo regression if it is post any illness. So, like, because of the illness, like, or post the illness, like that child, or like for a reasonable amount of time, the child is not able to do his normal daily course and activities. But like later he picks them up. But in this case, the child has not picked up. So then this is not pseudo regression. So the other thing which I was thinking was like a defect was there from the very beginning, which caused a loss of the social and cognitive and language milestone. And now post the illness, the defect has become full blown to involve the other domains also. Could it be that like of neurometabolic sort?
So I think what it means is that the present illness has been triggered by fever, and at 7 years also, a fever has triggered some neurological worsening. So we have two common things. Fever seems to be trivial enough, but good enough to trigger a neurological manifestation. So we have one common issue happening at 7 years and also at 10 years. But even before 7 years, there has been some problem. Okay. So now, if you had seen him at 6 years of age, before that 7 year motor deterioration occurred, what was your probable cause of the brain damage? A bit of a delay, not significant in motor, but a definite delay which is persisting up to 7 years on language and cognition. What would be your possible etiology at that time before 7 year deterioration occurred?
Autism. Autism.
Autism should have been picked up even in the first year.
And so again, let us split here. Do autism children have cognitive delay?
No, their IQs are even better than normal.
They don't have cognitive delay.
They will be able to talk, but the communication, they will not be able to communicate.
Correct. So see, autism in the beginning, it manifests as delayed talking. It is clinically manifest as delayed talking, which is more of a communication problem and not an indication of less IQ. Understand? Our problem as a doctor is that at that stage it may be difficult to judge the different components. So superficially it may look like less IQ, but then you'll have to dissect it, right?
So then what could it be? What could it be? So now let's go back again. At that time, there was only cognition and language. Okay. So no cerebral palsy. Then which part of the domain is involved and why is it involved? Which part of the brain is more defective which part of brain function is affected.
So cognition was how bad at 7 years? Means what all could the child do at 7 years?
She was she was able to play by herself, sir. She was able to feed. She was able to be on her own, but able to communicate or talk. She was able to call the father, not exactly Papa, but she used to say Dada, Baba.
Again, now in this case, we realize that most of our assessment of cognition is based on the child speaking. So we would ask, would she be able to tell stories? Would she be able to recite nursery rhymes? All this is based on expressive speech, our assessment. But then you'll have to shift gears now. So you will have to ask what is her understanding, how complex commands can she perform. Those things will tell you something about cognition. Understand? Did you ask that? We were trying to judge at 7 years how bad it is, because as sir said, what is the etiology of these two domain affection at 7 years? Before that, respiratory illness.
I'll give you another clue. There's nothing went wrong in the first 7 years for us to connect it to a brain damage. Could it be something that happened immediate perinatally, or maybe intranatally, or maybe prenatally, which was silent, which was not known to a doctor either, which we will never know today, but we will see only the. Pardon?
Red
Rett syndrome.
Rett syndrome is a normal female child who, around 2 years of age, suddenly deteriorates. There is a regression sudden. But you are right. You are thinking of something that he is born with but took time to manifest. That's a Rett syndrome. Yes. So what is that? Some metabolic. Okay. So could be there is any which is the most common metabolic disturbance at birth, which is just not noticed and comes to us only with subtle brain damage. Excellent. Hypoglycemia. Hypoglycemia is easily overlooked. Okay. If the child is not drowsy but was not very active, well, did not throw up a seizure, still there could be hypoglycemia. And Dr. Udani has done a lot of work on this to say that that's very commonly missed. And of course, in this child, therefore, you go back and say, was he a child who is susceptible to that kind of hypoglycemia? What do you think?
Full term. 2.5 kg and full term is not susceptible.
Very good. So that is not the cause. Did he start feeding well? That's the next. Suppose he sucked well, but did not get anything. Okay. And went about. So that's hypoglycemia could be subtle, but would not have presented with seizure at that time, would have presented with poor school performance. Okay. So here, metabolic, he gave an idea about Rett syndrome. So could it be some metabolic disorder which seems to be come and go, which seems to be worse suddenly, you can call it regression, and therefore search for such a probability. And I think that's what we discuss at this point of time. So it is certainly seizure would be there. Now, last question: why did the brain damage occur earlier? Got worse after 7, but a seizure came at 10 years. Can I fall down today and then have a fracture after some time? It's almost like that, no?
neuronal plasticity.
So what exactly is neuronal plasticity? We'll clear that and then we'll come to this.
What is neuroplasticity?
What do we mean? Means
He
our
will
concept.
answer. He talked about that. Tell us what is neural.
Me, Regenerate and remodeling of the neurons during the early stages of brain development.
Very good. So that doesn't come as seizure. That comes as typically a Broca's area speech. Okay, we say that are you left-handed or right-handed dominant brain, but Broca's area says that even a contralateral area can start functioning. That is neural plasticity.
So basically, neuroplasticity is that a function of a part which
Damaged.
is damaged can be taken up by other areas when early in life, when it is all ready to, be remolded
But
that way.
taking over function, not damaging manifestation. Seizure is not taking over function. You are right. You gave some thought. So now use the other word for what is happening.
White matter neurodegenerative disease can have seizure as late manifestation.
Okay. So neurodegenerative disease, you are saying it's a slowly progressive neurodegenerative disease and has now started involving the gray matter.
But why after a long time? That's the question. Can you use a similar other word for a seizure? And that is epileptogenetics. Epileptogenesis takes time. Okay. A typical birth injury, severe, by day 3, day 4, the child has thrown up seizure, and thereafter the seizure stopped. And seizure may come after 2 years, 3 years. The first seizure was an acute damage. Subsequent seizures is a brain damage permanent, and that is epileptogenesis. Okay. It takes time for a damage to manifest as a seizure, but an immediate seizure is an immediate damage. That is what it is. So I suppose, so we have now probably a slowly developing metabolic or a neurometabolic neurodegenerative disorder, but not CP, not anything else.
So first give us your provisional diagnosis and then we have the child, right? So we'll examine.
Summarizing, 10-year-old female child, second by birth order, born out of third degree consanguineous marriage with history of status epilepticus, with fever, with delayed development, with neuroregression, with, with significant calorie protein deficiency, can be a fever triggered convulsion in a neurodegenerative disorder with language and social delay, can be a predominantly gray matter involvement or both matter and white matter involvement.
So in your summary, you should bring out the fact that the motor part was initially okay till 7 years and then worsened after a unrelated illness. That is what brings out that, the respiratory illness worsen. You get my point? If it was a neurological illness, meningitis, he could have had residual deficits and that is explainable. But an unrelated illness made him go down on the front. That part should come in the summary. You get my point? To bring in a neurometabolic disorder.
So all that you would have said is that the disease is still active at 7 years and same at 10 years, and therefore the manifestations have been triggered to also give further down. But who can go down when the disease is active? And therefore, active disease is a persistent neurometabolic or therefore causing degeneration. So I think that's why you said epilepsy, right? No, you did not use
Status
yeah.
epilepticus. This episode was
Yeah,
called
yeah.
status epilepticus.
So I won't call it epilepsy also. I would call it recurrent seizure twice in same episode. Okay. Epilepsy is not triggered seizure. Okay. This was triggered. Yeah. Good.
Sir, since she had bronchopneumonia and then loss of milestone, should we attribute it to hypoxia?
I was going to discuss that. Then we discussed many other things. So you tell me, can you attribute it to hypoxia?
Is phallostatrology hypoxic? Or he has got good oxygen saturation?
It's hypo.
Hypoxic, no? How often he throws up a seizure? He has a chronic persistent hypoxia. Does he throw up a seizure?
And also, she's also saying whether the motor delay can be attributed to hypoxic damage. So, give us your thought. So, what you would have said is that even in the worst scenario, if that child would have developed a infarct at that time, it would have been a localized motor problem. So you could have had a hemiplegia after the hypoxic illness or something like that, but not general delay of earlier achieved motor milestones. You
And
understand?
therefore, at birth, you call hypoxic ischemic, not hypoxic alone. Hypoxic ischemic, and it's ischemia that causes damage, not just the hypoxia, right?
Child is
बच्चे को लेके
She's 10 years. No? कुछ नहीं बोलती, पहचानती है ना आपको, सबको पहचानती है, नहीं डॉक्टर से डरती है, नहीं किसी के पास भी ठीक रहती है. Okay. Come closer and talking. Yeah. Now somebody else first takes a mic, then lastly she would talk. आप बैठे इधर, आप बैठे. Come on, come on, before then have a look. First start. Who has not talked much? I think today both of you are not, you're not angry with us. So please come forward. Yeah. Come on, start talking.
Child is comfortably sitting, both upper limb and lower limb wasting present.
Interested in surrounding.
Eye to eye contact present. Is severe thin. Severe thin.
severe thin, as in you think her height is okay for 10
No.
years?
It is less
Stunted.
than stunted.
Stunted also, no? So she's stunted as well as wasted.
Degenerative disorder, stunted and wasted. No, it must be chronic infection. No.
feeding also.
Okay. So it's a progressive disorder, indirectly affecting her mobility, her appetite, and many other things. Okay, looking after socioeconomic group, several, and therefore there. So if you look at her subcutaneous fat, it's not so bad. Okay, she's not wasted. She's small weight. She's definitely stunted, and to that extent, possibility she has no movements. Therefore, her intake is also that way required is smaller, and that is maintaining her reasonably. Those certainly things. Okay, fine. Her head looks big, right?
It looks
So
compared to body.
no,
but
compared means yes. After
measurement.
all of us have a small head as compared to the body, and that's normal. But her at 10 years of age is a large head, right? So what's your comment on that?
Sir, because she catched up her development till 2 years, she was fine with two domains of development. So it was not from birth.
Right. So you would have said I'm not sure whether it is a large head. I want you to measure it, and I will call it possibly not a large head. Okay. But suppose it's a large head. Then you think the neurodegenerative disorder was a large head. You are degenerating. No, neurons are degenerating, and the head is increasing. Syphilis is not a part of neurodegenerative disorder.
Because of accumulation of any metabolite or any substance, there is like a progressive loss of the milestones or the functions. So in that way, so metabolite accumulation. Cana-1 Alexander disease.
Space occupation is the cause of large head. He said hydrocephalus. And what can be space occupation? So something storage. Storage has that. Look at Tay-Sachs, for example. Okay, they have a large head. Syndromic people, Alexander syndrome, metabolic disorders. Okay, which metabolic disorder has a if it's a large head? I forget. Uh,
Alexander and Canavan.
yeah. So Canavan, yes. Alexander, yes. Tay-Sachs, yes. So these are storage disorders and therefore head. Probably not, but she will tell us the head circumference and that. Was that abnormal head circumference?
48 centimeters.
Okay, fine. So we go further now. All right.
Some more observation findings we expect from you.
Her eyes look very prominent. Huh? I must rule out a thyroid.
So this facial hairs and like the ones which she's doing as stereotypy.
So very good. There are some repetitive movements, like she seems to be chewing on something all the time, though there's probably nothing in her mouth. What about the eyes, sir said? Can you observe something in the eyes?
Unibrow, then joint eyebrows, left eye ptosis.
Drooping of the left upper eyelid as ptosis.
First thing you observe is they don't seem to be equal. Now you have to find out why. So on inspection, it looks like the left eye there is ptosis, but you will need to cross check that on further examination. Anything else on observation?
Ankle contractures are present.
When you closely observe, I also thought the same, but now in between she can move the
Exactly.
eyelids
That's
well.
why I said that you need to.
Yeah.
Okay, ankle, you said something.
Ankle contractures.
So, just for technical correction, you are just inspecting her. You have not palpated her to confirm that it's a contracture. It is better to say that the ankle posture looks hypertonic or spastic. I will confirm on examination, right? Contracture will be picked up really on examination. You don't know whether she's able to move or no.
What about her feet?
So they said a spastic posture. Okay. Then
The synorchis is present.
okay. Fine.
So now we'll examine her, but one of you first tell us what do you expect on physical examination?
Power, she's moving all.
Looks normal.
No, more
Tone
than 3 by
spastic.
5.
Okay.
It
Abnormal
is the
movement.
tone. In
Which
upper loop and
abnormal
lower left,
movement
not present.
may not be seen when she's sitting like this. And on examination, you can pick up. Intentional tremor. Even that time, you were something today, and then she will show you this kind of dish. So make sure that it is not there. In coordination, probably not, but we'll have to test it. Okay. Sensory system. we'll have to test it, but we don't anticipate trouble. Cerebellum, we don't anticipate trouble. Okay. Vision, hearing,
Child is
probably
able
normal, but we need to test it as well. Okay. So now somebody quickly do a neurological examination. We can put her there, lying down, right? तो जरा थोड़ा से चेक करते हैं ना आप यहाँ से ऊपर चलो राइट जरा संभाल के रखो come on very one of you senior you are all seniors now don't forget come on very good just hold on.
Motor system examination. Those are higher mental functions, conscious, alert. Then
We did that. On observation, we did
Motor.
that. Now quickly examine physically.
It's normal
It should go by this.
Till what age thumb sucking is normal, or at what age it is normal, and then till what?
1 year, till 1 year, it's normal.
Till 1 year, 2 years, 3 years, we heard everything. The baby putting the hand in the mouth. Three months. Mouth.
put the hand in the mouth put fingers in the mouth when does that occur unless that happens you can and why they don't open the fish to begin with why do they take 3 months grasp reflex when grasp appears then only they can and that happens at 3 months and thereafter continue doing it they are bored or they are hungry okay but thereafter they know if they are hungry they have to and if they are bored to fight with somebody once that happens then that habit appears right but sometimes the habit continues for a long time so this is certainly part of regression in terms of habit, but we may have to ask her whether she has been doing it even earlier or not.
so hypertonia of all four limbs because of reflex more than 3/5 in all four. So reflexes, knee jerk is 3 plus, ankle jerk is also 3 plus. So she has got dynamic contractures at bilateral ankle. And so clonus in such case, ankles are contracted. So like what do we?
So that's what. If get a reflex, then you may get a clonus also. But if you don't get a reflex only because of contract, then you will not get a clonus also. Okay. And you should describe this as a equinovarus deformity of the foot. Okay. Fine. So yeah, I think that's any other positive findings that we missed.
See, for every neurodegenerative disorder, besides neurology, you must also often there are skin manifestation. Sometimes even for a cognitive and global delay, there could be basal ganglia, peripheral neuropathy, all association of many neurometabolic disorders. So just make sure you are not missing anything. Now, if you have an upper motor condition and spasticity, how will you pick up a peripheral neuropathy in that?
Palpable nerves.
Palpable nerve is not a good.
Peripheral nerve is an infection.
Because of repeated trauma, ulcers, or some wound.
Trophic ulcers.
It's a symptom that is. So just keep in mind every disorder you mentioned, skin lesions, there's no neuropathy, there's no there's no cerebellum. You have examined all parts of the thing, and those associations can make you narrow down the probability, right? Nothing else, right? प्लीज जा सकते हो थैंक यू करेंगे डॉक्टर आपके साथ हाँ डॉक्टर बताएंगे आपको ओके
On examination, child was afebrile, heart rate of 110, and anthropometry. Sir, everything similar. Anthropometry, weight is 15 kg. Height is 113 centimeter, less than -3 standard deviation. Head circumference 48 centimeter, less than -3 standard deviation. BMI is 8.5, less than -3 standard deviation. Upper segment length is 45 centimeter. Lower segment is 65 centimeter. Upper segment to lower segment ratio is 0.69, which is disproportionate for 10 years. CNS examination same. And other system examination, per abdomen, soft, non-tender, no organomegaly, respiratory, air entry bilateral equal, no added sounds, CVS, first and second heart sounds present, no murmur. Diagnosis: 10-year old female child.
You said upper segment to lower segment is disproportionate. So what does it mean?
At 10 years of age, we expect 0.9, 0.69 the child has.
Correct. So which means which is shorter?
Upper segment is shorter.
Which means what?
Short trunk.
Which means what?
Uh,
Short trunk due to what?
the axial growth.
So spine, there is something wrong with the spine. You have to take it forward. So now you have to start thinking whether any of the neurodegenerative disorders would have a spine affection where the spine is short. You understand? So
MPS. Mucopolysaccharidosis.
very good. So mucopolysaccharidosis. So then you have to think whether it fits into any of those. Okay.
Diagnosis: 10-year-old female child, second by birth order, born of third-degree consanguineous marriage with uh, convulsion, presenting with convulsion, with neuroregression, with disproportionate short stature, with microcephaly, with significant calorie protein deficiency, no cerebellar involvement. But since she had the movement pyramidal, I had
So,
written no extra pyramidal.
yeah, so some extra pyramidal movements.
Signs. No signs of raised ICP or meningitis. can be a possibly a case of mucopolysis or Rett syndrome.
So defend both. Why mucopolysaccharidosis and why Rett?
So child has coarse facies, and there is a disproportionate short stature, and there is neurodegeneration, but there is no organomegaly. Um, but these are favoring to MPS. And Rett syndrome, the onset is late, but usually Rett syndrome, the regression starts at around 3 years. But here the regression is 7 years. Since she is a female with microcephaly and neuroregression, Rett syndrome should be considered.
Okay, but in the first phase, there was this language delay. So in this child, when you say Rett syndrome, you have to have absolute normalcy and then regression. So that is probably a strong point. Okay.
I think tremors are the highlight of Rett syndrome, or not tremors, but the pin rolling moments.
Okay. Fine. Investigations.
So an investigation, CBC, HB is 8.4 with hematocrit of 28.3 and MCV is 75, MCH is 22, WBC count is 2170 and platelet counts is 1 lakh and reticulocyte count is 0.9, which is by pancytopenia picture with normal retic. And on peripheral smear, hypochromia present and normochromic cells present and microcytic are present. And lympho are 60%, poly 40%. Platelet adequate on the smear.
So why you said pancytopenia?
WBC are less.
Hello.
And platelet is also less than 1,50,000. And
You said 117.
1 lakh.
1 lakh. Okay. So what is the explanation for this pancytopenia?
Can be some bone marrow involvement also. Storage disorder affecting the bone marrow. Can be,
Okay.
or some acute infection causing.
Is she having any acute
She
infection?
presented with fever. But on evaluation, we did not get any infective focus on examination also. But two
Any
possible.
third explanation?
Any nutritional deficiency, B12
Like,
deficiency.
yeah, B12 deficiency, because nutritionally she'll be poor, no? Yeah, good.
For 75.
But in B12, we expect MCV high.
Correct. So now then take
Dimorphic.
it further, dimorphic. Okay, so yeah.
We did a X-ray, sir. X-ray of the hand and spine. Only in the spine we could see there is a upper part, there is a the downward curvature is there, which is not typical of MPS, but still to get reporting from the radiologist. There are no oar-shaped ribs. We did a 2D echo. It is suggestive of mitral valve prolapse, moderate MR. And fundus we have done, no cherry red spot. And outside, actually, when she was admitted, urine for glycosaminoglycans was done, which is positive.
So if it turns out to be MPS, it will be which type? Come on, you people are more well versed than us, no?
They say that this MPS is without hepatosplenomegaly or without eye signs, but I would not recall the name of a syndrome, whether it's she or whatever. We don't know.
Considering the amount of delay, it has to be the first, second types only, right? So we have to see where it can best fit in those. So again, next time you have to tell us what it turned out to be.
Yeah, I had counseled the mother for genetics studies, but she's not willing, sir. And she has already an elder child, 21-year-old, and she's not expecting next pregnancy. She has denied the study.
Okay.
Don't see a storage here really in any sense. I can see that spine is certainly short, but there are no other finding. Other bones are all right, eyes are all right. Face is also not coarse or anything. I mean, she's looking very pale, but therefore, yes, you are right in thinking MPS because of a short spine, but no corroborative thing. Again, to me, it looks like that there have been two phases of this illness. One first coming with very little motor event and only cognitive and social, and then again further worsening. So disease looks like waxing and waning kind of, not waning, but further worsening both the times with fever. So we don't know whether it's some other metabolism, but that I think even sometimes investigations also may not pinpoint. Clinician can't go beyond that, right? But good. I thought it was a good case and well done.
Good. Come.
So sorry. Sir, unmute yourself, please.
Um, Child was diagnosed with some liver disease upon genetic studies, but he was lost to follow up in a peds gastro OPD since August 24. The child had a history of pica. ANC history was normal, registered at local hospital. Iron folic acid and calcium supplements were taken. 2 doses of injection tetanus were taken. One ANC scan done. It was told to be normal, uneventful antenatal scan. No history of medical illness in the family. Birth and immunization history. Birth history was also normal. Full term normal vaginal delivery. Cried immediately after birth. 3 kg birth weight. Discharge on day of life 4 and discharge was discharged on breastfeed. No history of neonatal jaundice. No history of NICU stay. Mother noticed yellowish discoloration of the skin since birth. Immunization status: the child is immunized till date by 1.5 years. Developmental history: gross motor runs, walks upstairs and downstairs one step at a time. Fine motor feeds and undresses himself. Social milestone: plays with peers and language, speaks in sentence. To summarize, history is appropriate for age in all 4 domains. Dietary and family diet: the child consumes mixed diet. The family consumes mixed diet, and the child eats from the same family pot. No significant family history. Birth and socioeconomically, the child belongs to lower middle class as per modified Kuppuswamy socioeconomic scale.
So to cut it short, present history is a 4-year-old child with fever since 8-10 days, right? And vomiting since last 4 days, which contained blood, right? Is the history now. So what are your thoughts? Which febrile illness gives rise to vomiting after 5-6 days, and then that vomit has blood? What is the correlation or what is the thought process?
Take 4 days. मतलब after fever to decompensate.
Okay. So you're saying an infection like leptospirosis can do that. Okay, then integrities we'll discuss. Then what else?
On history, there is also a history of some liver disease. So
No,
fever.
no, liver disease. See, they've told you liver disease. That is not learning from today's complaint of fever and him. How we can go towards and analyze. That is the learning, right?
Action has to be hemolysis.
Correct. How can infection trigger hematemesis? That's what I'm asking.
Mucosal erosion.
Mucosal bleeding or DA, thrombocytopenia. Infection associated with thrombocytopenia like dengue, but which is very rare. coming as hematemesis. Or a child going in DIC.
EH,
Okay.
EHPV, EH portal venous.
Is right, but EHPVO related to the fever. So what I'm trying to broadly to tell you is we got fever and instead of saying is there some wrong way to explain this everything wrong. So there must be something in the past. Similarly, what to decide here is can this CCK fever cause metamesis on the 7th, 9th day? Different mechanisms we discussed in sepsis, child from thrombocytopenia, the child drug-induced gastritis, whatever. And if our answer is no, it doesn't seem to in, then it you probably metamesis in this is past and not related to this fever. That is the way you will have to
Everything which comes after 3 days after onset of some other symptom is complication or various really action and commitments. Onset diabetes, then severe pain, common in pediatric practice, and then